Hello and welcome to SRG's Medicine. Today, in this video of Respiratory Medicine Series, we shall be continuing our journey with hemoptysis. So, the contents of this video are history taking, in which we will be dividing it on history taking about hemoptysis and other history. Then we'll be summarizing the video. So, firstly, talking about history taking about hemoptysis. So, the first and foremost thing, as I've already mentioned in the previous video, is that we have to confirm whether it's actually hemoptysis or not. So, the next thing that we'll be talking about is about the amount of hemoptysis. So, in amount, we can classify hemoptysis as massive or non-massive hemoptysis. So, here, though there is no agreed upon volume, that whether this much volume would be called massive or this much would be non-massive, but the general guideline is that greater than 100 to 150 milliliters at a time, or greater than 400 milliliter uh, of blood in 24 hours are considered as massive hemoptysis. And this is quite important to classify whether it's massive or non-massive because the rapidity and the extent of the workup depends largely on this fact. So it's quite important. Actually, it's the second most important part of the history taking about hemoptysis because the first one is confirming hemoptysis and the second one being knowing the amount of hemoptysis. So let's take our stance of the year. The first thing was that we confirmed hemoptysis, and after confirming hemoptysis, we asked the questions or we just viewed directly the amount of blood and then we categorized it as massive or non-massive. So if it is massive, then the first and foremost thing that we need to do is managing of vital or stabilizing the vital, because in cases of massive hemoptysis, there are usually two dreaded conditions. The first one being asphyxiation due to blockage of the airway by blood, and the next thing being hypovolemic condition due to excessive loss of blood. So the next questions that we will be asking about is that whether it's a first or recurrent episode, because in most of the cases, the episodes might be the first one. That is, so we have to ask whether it's the first episode, or we have to ask whether there has been previous hemoptytic episodes before. And if there has been hemoptysis episode before this, then what was the quantity of the hemoptytic blood before this, and what was the frequency? That is, whether it was just a recurrent going on over a long period of time, or whether it was just occurring a few days before and today again it's occurring. So we have to ask the quantity and frequency. The next thing that we'll be asking is that what were the tests that were performed on those conditions, and what cause was found for causing hemoptysis then, that is previously causing hemoptysis. So these two questions are quite important, and these are a bit like different as well than other questions, because here we have to see, because if these tests or these diagnoses are quite recent, then we can rely on it. However, if these are not recent, then these are not to be relied upon, because sometimes there might be more than one conditions in a more than 2 to 3 conditions in a patient, and one of those might be causing hemoptysis. So these are quite different things. The next thing that we'll be talking about is we'll be talking about character. So in character, we'll be classifying the hemoptysis as the presence of blood-streaked sputum, or presence of blood clots, or presence of frank blood. So by frank blood, I mean liquid blood. So here on blood-tainted sputum, so we can classify it further based on the character of the sputum. So by that, we can get a differential diagnosis. So the first one being, if the blood-tainted sputum is frothy, then we have to consider the causes such as congestive cardiac failure or pulmonary embolism. If it is purulent, then we have to talk about infectious causes such as bronchitis, pneumonia, or bronchiectasis. And if it is foul smelling, then we have to consider about anaerobic infection. So as I've also mentioned in the previous videos, that the management of aerobic and anaerobic lung infections are quite different. So this is an important question. And the next thing that we'll be asking about is about the clot. So if there's presence of blood clots, then the conditions might be tuberculosis and lung carcinomas, whereas if there's presence of frank blood, then the causes might be foreign bodies or coagulopathies or carcinoid tumors or Goodpasture syndrome. Here, I'd like to mention that this carcinoid tumor, though it is a neoplastic condition, it presents with frank blood, but other lung carcinoma most commonly presents with blood clots. So that was about character. So taking our stance again. So we had talked about classifying it as massive, non-massive, and then stabilization of vitals. So what do we do now? So after that, I have to ask whether it's the first episode or whether it's a recurrent episode. So after asking that in a case of non-massive hemoptysis. But if it is massive and we have stabilized the vitals, then we can again go on to asking the same questions. So if it is the first episode, then we have to ask about the character of hemoptysis. So here by character, I mean whether it's a presence of blood clots or blood in sputum only, or there's presence of frank blood, and what was the character of sputum. So asking all those questions, we get a short list of diagnoses or short list of the causes which might cause hemoptysis. And if it's a recurrent episode, then we have to match the uh, cause, that is previous cause, to the character of the present cause. For example, if the patient was previously diagnosed with bronchial carcinoma, but now he again has hemoptysis after a long time, and then we have to see whether this hemoptysis matches with that of the bronchial carcinoma. So if it is matching, or if it fits the previous diagnosis, then bronchial carcinoma is most likely to be the cause for hemoptysis. However, if it doesn't fit the previous diagnosis, then we have to keep it just on the back of our mind, though not completely isolating it, just keeping it on the back of the mind while considering other diagnoses as well. So the general tips for now is that the patients usually will overestimate the amount of bleeding. So as a clinician's point of view, nothing can replace your direct observation. So direct observation is kind of like a boon for diagnosing, or a quite good help for diagnosing the causes of hemoptysis. The next thing is that the character of the um, current condition, if it fits the previous diagnosis, then keep it on the top of the differential diagnosis list, and if it doesn't, then the previous diagnosis is quite uncommon. Now, the next thing, or next questions that we'll be asking about is on the basis of onset. So on the basis of onset, we can ask is that whether it's a sudden onset of hemoptysis, or whether there is presence of few episodes regularly followed by exacerbations. So the conditions or the causes causing these different kind of presentation might vary. And the next thing that we'll be asking on about is about the precipitating factor and the relieving factor, though they are not quite useful, but we are asking it as a regular, just asking it purpose. The next thing is that we'll be talking about other history. So history other than specifically hemoptysis. So here we'll be asking about associated pulmonary signs and symptoms such as clubbing, stridor, cyanosis, or cough, dyspnea, pleuritic chest pain, etc. And then the next thing is that we'll be asking about the other system sign and symptoms. For example, in cases of cardiovascular diseases, the patient might present with bradycardia, tachycardia, or hypertension, or any other combination of these. And in the cases of hematologic condition, the patient might present with anemia or rashes or frequent bleedings or blood in the joint cavity, etc. The next thing is that if there's an infectious condition, then we might have to ask that whether the patient has fever, whether the patient has chill, joint aches, sore throat, or such. So if these conditions are present in a patient, then we might have to think that the cause for hemoptysis is most likely infectious. And for a neoplastic condition, there has to be some recent changes in the sleep, appetite, or recent weight loss or weight gain. So that are the questions that we'll be asking about. And the next thing that we'll be asking about is the past medical history. So in past medical history, we'll be asking about any other comorbidities rather than those with hemoptysis. So we might ask about whether the patient has a diabetes, whether the patient has other fracture conditions or any other condition. And then we'll be asking about previous history of trauma, specifically chest trauma. And the other question is that we'll be asking about the diseases which were previously treated, because sometimes previously treated diseases might again come relapsing. So these are most commonly seen in the cases of neoplastic condition or tumors. And the next condition is whether the patient has recent pulmonary invasive procedure, because in the cases of bronchoscopy, it is quite common to injure the blood vessels in the bronchial area, so thereby leading to hemoptysis. The next thing is that we'll be asking about the current or recently used drugs, and we'll be also asking about the family history of diseases such as hypertension, tuberculosis, coagulopathies, vasculitis, etc. And we'll be asking about social history. In social history, we'll be asking what's the occupation of the patient, because some occupational exposure might lead to hemoptysis or might predispose to neoplastic conditions such as asbestosis, carbon, silica, or fumes. And we have to ask about the lifestyle, whether the patient drinks, and if drinks, how much, whether the patient smokes, and if smokes, how much. And we also ask about the eating habits of the patient. The next thing that we'll be asking about is the systematic question. Here, by the word systematic question, I mean to say that these are just for reinforcing the fact, reinforcing your facts. That is, if you suspect a condition, for example, let us consider tuberculosis. So if you consider that the patient has tuberculosis, then you ask specific question about tuberculosis such that you might get a confirmation that your diagnosis is correct, or your diagnosis might be incorrect, so you move on to the next diagnosis. So that's reinforcing your facts through the systematic question specifically about the disease that you suspect. So the last and the important one is that you have to review all the important findings with the patient. So all the findings that you have found till now through history taking needs to be reviewed. Two things that it helps in is that the first thing being that the patient, it helps to confirm your facts are right, and the next thing is that it helps to find out some missing facts in your history. So this is quite important. So now let us see whatever we have seen till now. So the first thing was confirmation of hemoptysis. After confirming hemoptysis, now we moved on to questioning or seeing whether it was massive or non-massive. So if it was massive, then we straight on stabilized the vitals and then moved on to the next question. But if it was non-massive, then we moved on to next question directly. That is whether it was first episode or whether it was recurrent episode. Then if it was first episode, then we checked its character, and then we formed a list of differential diagnoses. So here by character, I don't just specifically mean the blood tinge sputum clots or frank blood one characters, but all other characters as well, such as onset, timing, exacerbating, and relieving factors. So overall, I have mentioned here in the character. And if it's a recurrent episode, then we'll just match it with the character of the currently presenting hemoptysis. And if it fits previous diagnosis, then the previous condition might be the cause for hemoptysis. But if it doesn't fit, then the previous condition is quite a rare one for causing hemoptysis this time. So after that, we ask about many associated signs, symptoms, family history, social history, lifestyle, occupational history, and other many more. And by that, we get something. That is, if there are associated respiratory signs and symptoms or increasing risk factor for the respiratory diseases only. So just for respiratory diseases, then we have to focus our investigation, that is further investigation after this, whether there be lab investigation or clinical examination, then we have to focus it on respiratory system, more specifically on respiratory system. However, if there are other symptoms along with the respiratory symptoms, for example, along with clubbing, there's presence of splinter hemorrhages, or there is presence of edema, then we might have to think of other conditions. That is other system condition. That might be cardiac causes, there might be vasculitis, there might be coagulopathies, etc. So now summarizing this video. So the first thing is amount of hemoptysis is the second most, only after confirmation of hemoptysis. So the second most point in the history taking, because the rapidity and the extent of investigation depends upon the amount of hemoptysis. The next thing is associated signs and symptoms direct us towards diagnosis and helps us narrow down our investigative tests and examination. And the final thing is that reviewing all the important findings with the patient helps us by confirming as well as find the missing facts in history taking. And here, the last one, which I have mentioned in blue, which is of clinical importance that I'll be covering in the coming videos, is that sometimes red sputum might not be hemoptysis. So the patient might have red sputum, but it is not blood. So these conditions are collectively known as pseudohemoptysis. We shall be talking about it in the coming video. Hope you enjoyed it. Thank you. Stay tuned, and please do comment on your questions or feedbacks.